Good evening. Welcome to this Ask the Expert event focused on breast cancer. Tonight, a panel of experts will share helpful information about breast cancer screening, diagnosis, and treatment. We will also answer your questions live. To submit a question for our panel, simply drop it in the chat here on Facebook. Let's meet our panelists. First, we have Dr. Kay Blanchard, a general surgeon and breast cancer specialist with Mary Washington General Surgery. From Mary Washington Physical Medicine, we have Dr. Rachel Coggins. Dr. Coggins is a doctor of osteopathy, specializing in physical medicine and rehabilitation. Next, we have Dr. Menon Mehta, a hematology and oncology specialist with Virginia Oncology Care. We are also joined by Dr. Ronnie Talukdar, Medical Director for the Imaging Center for Women. Dr. Talukdar is a board-certified radiologist with fellowship training in breast and oncology imaging. Next up is Jen Schaefer, a breast cancer survivor and the integrative medicine coordinator with the Mary Washington Healthcare Regional Cancer Center. And finally, we have Ashley Sisson, cancer nurse navigator with the Mary Washington Healthcare Regional Cancer Center. Welcome, everyone. Thank you so much for joining us this evening. Dr. Talukdar, I'd like you to start the program this evening by telling our viewers a little bit about breast cancer screening. What is it, and why is screening so important for breast cancer?
Thanks, Emily. I appreciate everyone joining us here tonight. As many of you may know, 1 in 8 women will get breast cancer in her lifetime. 3/4 of those women have no family history of breast cancer. Oftentimes, the first time somebody finds out that they have breast cancer is on their yearly screening mammogram. When we find breast cancer on a screening mammogram, we typically detect it at under 1.5 centimeters in size. Typically, when you feel it during a self-breast exam or clinical breast exam, it's about up to 2.5 centimeters in size. And so that's not a big difference, but that difference can be the difference between life and death. When we look at breast cancer, the smaller that we detect it, the better patients do. And if we can detect it small enough, you have about a 99% survival rate, which is huge. We recommend starting yearly screening mammograms at age 40 for our average risk patients. For high-risk women, high-risk patients or women that have a family member that had breast cancer before the age of 40, we recommend that you start about 10 years before that first-degree relative. So that's sister, brother, mother, father. You want to start about 10 years before that. Your risk is determined by a variety of factors. Those can include your family history, your hormone exposure, your reproductive history, your age, the density of your breasts, underlying genetic mutations, obesity, smoking, other factors as well. When you get your screening mammogram at the Imaging Center for Women, we do a risk assessment taking into account all those factors so that you'll know your individual risk when you leave. Many people also ask when you should stop doing a mammogram. The literature talks about stopping at about 5 to 7 years of life expectancy. But for most of us, we don't really know when that is. And we kind of hope that that's not anytime soon. We've had patients in their 80s and 90s that we've detected small breast cancers on, that we've been able to get to treatment, and that have lived out their natural lives and done well. So, I just say continue as long as you're able to do so. Since the beginning of regular screening mammograms, we've seen the number of women that have died from breast cancer decrease by about 40%, despite the incidence or number of breast cancers increasing by about 0.25 to 0.5% per year. So fewer women die of breast cancer despite there being more breast cancer today. For those women who are at high risk or have dense breasts, we also recommend supplemental imaging. So in addition to your yearly screening 3D mammogram, we recommend either breast ultrasound or breast MRI, or coming soon, abbreviated protocol breast MRI. After you get your risk assessment after your screening mammogram, it's good to have a conversation with your primary doctor to kind of talk about what makes sense for you. Also at Mary Washington Healthcare, we have a high-risk screening program where you see a clinical breast specialist who can kind of look at everything and really treat you as an individual and make sure that we're covering all our bases and nothing is missed. Now, everything up until this is for the patient that's asymptomatic. Just kind of the person that doesn't suspect they have breast cancer, but we want to make sure we catch it before there's symptoms. However, if you have a new lump, or you have a change in your breast size, or you have new nipple discharge, specifically if it's bloody or clear and spontaneous, if you have new unexplained pain, right? Unexplained pain is not you've just got this Peloton and you went really kind of crazy on it for a little while and now your breasts hurt. It's more of the, I haven't done anything new and I've got this pain. Definitely call your primary care, get in for a diagnostic mammogram and ultrasound. Ultimately, the biggest take-home message is really get your mammogram every year on time. We have these phones, we have all these pieces of technology that help us remember. Put it in your phone. We'll also send you reminders to help you in case you forget, but please get your mammogram every year. It really does save lives. Thank you, Emily.
Thanks, Dr. Talukdar. That's great information and good encouragement for women out there who might be putting off a mammogram. Don't wait. Make your appointment and see a provider today. Thank you. Dr. Blanchard, I'd like to spend a little bit of time chatting with you about the role that a surgeon might play in a patient's journey as they undergo treatment for breast cancer. So some patients who are diagnosed with breast cancer may have surgery as part of their treatment plan. Can you talk about what patients might be candidates for surgery?
Well, in all honesty, just about everybody who's got breast cancer should likely have some form of surgery, be it a lumpectomy or a mastectomy. And the kind of surgery will depend mostly on stage of the cancer, ultimate treatment options. There are a few patients who don't immediately go to surgery. Those are patients who may benefit from some sort of pre-surgery treatment. And when I say that, it's either chemotherapy or some endocrine or treatment with like tamoxifen or a hormonal treatment in order to either shrink or maintain the size of the tumor, make sure it doesn't progress. When this COVID first started last year, one of the national guidelines was to delay surgery for breast cancer patients, especially those who were low risk, hormonal positive patients, by 3 to 6 months by giving them a pill like tamoxifen to delay surgery, thinking that in 3 to 6 months, the timing would be safer in the hospitals, which clearly hasn't really happened. But in all honesty, most cancers are actually treated by surgery. Most other forms of therapy are usually temporary or in order to help control the tumor. There are patients who are not really good candidates for surgery in that they have underlying health issues that would preclude their going to the operating room. Another situation where surgery may not be indicated if it's a patient who's got metastatic disease, in case that treatment of the primary tumor is not really as part of a survival benefit. So as a surgeon and a breast surgeon, most breast cancers are treated ultimately in some form or another with surgery.
Thank you. So how would a patient prepare for surgery?
That's a really good question. And a lot of that depends on what kind of surgery the patient is getting. Most often we would prefer to do, say, a lumpectomy, which is like a treatment of taking the tumor itself out, as opposed to mastectomy, which is taking the whole breast off. And both of those have different ways of preparation for surgery. For lumpectomy, it's an outpatient procedure, essentially. Most preparations for that is to sort of understand that, yes, there's going to be some discomfort. Most of the times, there's no change or effect of the size or function of the breast itself. On the other hand, if a mastectomy is indicated, whether it's the patient's preference or there's a genetic predisposition or it's a large multifocal type tumor, a mastectomy is indicated, and that's a lot bigger way of trying to prepare for that kind of surgery. Usually talk about reconstruction options and have the patient talk to a plastic surgeon to talk about that. But that has a lot of impact on how a woman can identify with themselves. Some women, that's a very important part of their self-identity. And so may need to talk to therapy to kind of wrap their head around that this is not why they're a woman, and that doesn't, change their identity. So in preparation, talking to as many people as possible, friends, family, therapy, surgeon, other support group, navigators are important, and to try and understand what all's entailed with the surgery and the afterwards.
Thank you. So you mentioned afterwards. So what can a patient expect in terms of recovery from breast cancer surgery?
Again, that will depend on what kind of surgery they get. With lumpectomy, it's most women don't have a lot of pain, except the ones who have, say, treatment in their armpit, the axilla. If there's a lot of lymph nodes taken out, we worry about lymphedema, which is arm swelling. And we talk to Dr. Coggins and have her see these patients to wrap their heads around how to prevent lymphedema. So how does the recovery occur? And that has a lot to do with kinds of surgery. With regard to recovery from mastectomy, in all honesty, it's not going to be ever you. But by the same token, if you do a mastectomy, the risk of a second breast cancer is lessened quite a bit. And that's why some people elect to do that way. But there is a fair bit of pain that can be involved with it. It really depends on the patient's tolerance for pain and whether or not they get reconstruction. I often do recommend reconstruction because I think that women feel better about themselves if they do have some form of a breast left.
And Dr. Blanchard, what about women who are of childbearing age and go through a breast cancer diagnosis? Is there still hope for them if they would like to breastfeed their children in the future?
Yes, the breast is really kind of forgiving. It will work its way around a lot of times. If you do lumpectomies and then follow that with radiation, the breast itself might be a little less able to produce milk. But for the most part, women can breastfeed. The sensation may not be as much as before, really depends on where the cancer is. If it's very close to the nipple, breastfeeding might be a little bit more challenging and sensation may not be as forthcoming. But most women are able to breastfeed afterwards. Now, clearly, if you have a mastectomy, that's not going to be an option.
Thank you, Dr. Blanchard. Dr. Mehta, early on, Dr. Blanchard mentioned chemotherapy as part of a patient's treatment plan. Can you tell our viewers a little bit about medical oncology and what role medical oncology plays in a patient's journey?
So medical oncology is a specialty that works in conjunction with the surgeon as well as other team members of our multidisciplinary team. And we play important part in the prevention of the breast cancer, diagnosis, management, and assess the risk of it coming back or recurrence, as well as we help try to prevent the recurrence. We also help decide if one's going to need a radiation. In all honesty, almost 80% of women that are diagnosed with breast cancer would not need a chemotherapy. In old days, we used to give chemotherapy to almost 80% of women, and now we don't have to do it for almost that much of number of patients. Only 15-20% of women who would need chemotherapy, we would help them identify based on their genetics, based on the risk factors, based on the pathology. We also help them identify what are the genomic markers that can identify who's going to be high risk for getting cancer and who can avoid chemotherapy. And chemotherapy is not the only treatment for breast cancer. There are multiple options that medical oncologists can help with, including endocrine therapy or hormonal therapy. There is a role for biologic therapy. There is a role for immunotherapy. And as a part of team, we get together, we discuss in tumor board, and we all come to the consensus to see which option is going to be the best to treat the breast cancer.
Thank you. So you mentioned, multiple options that may be available to patients undergoing treatment for breast cancer. So can you talk a little bit about maybe some of the expectations that a patient could have if they were coming in for chemo or if they were coming in for radiation or maybe a different treatment?
Yes. So breast cancer is a disease of variations. But in general, there are certain markers or receptors that the cancer cells express. One of them is estrogen receptor, second one is progesterone receptor, and third one is a protein called HER2/neu oncogene. And these are the receptors that will define what approach is going to be the best going forward. When a cancer expresses the hormones but does not express the HER2/neu oncogene, it means that the cancer depends on the hormones to grow. So in most cases, at that time, we can defeat the cancer and prevent the recurrence by modifying those hormone levels in the body or by downregulating those receptors. If the cancer expresses HER2/neu oncogene, we can take the help of biologic therapy that specifically target that HER2/neu oncogene, and it would downregulate that oncogene. If the cancer does not express any of those receptors, in that cases, we can take the aid of immunotherapy in conjunction with chemotherapy for the treatment. So all of those approaches are decided in a team-based manner.
Thank you. I love how you said defeat cancer, because everybody here on this panel, I think that's something that they have in mind every day when they go to work, right, is to defeat cancer and improve the quality of life for patients. So I'm glad you said that. Thank you. Yep. Dr. Coggins, I'd like to spend a little time chatting with you. Your specialty is physical medicine and rehabilitation. So how does your specialty play a role in the treatment of breast cancer?
Yes, absolutely. So physical medicine and rehab is kind of the medical specialty of how a patient is able to function and get around. So in regards to the cancer population, a lot of these patients will go through treatment, whether it be surgery or chemotherapy or radiation, and they might have some sort of impairment in their function, whether it's some pain, whether it's trouble moving their arm, or whether it's lymphedema, as Dr. Blanchard mentioned. So physical medicine and rehab can be involved kind of before treatment even starts, where we help to assess the patient and make sure that they are functioning well and they're going to be able to get through whatever treatment is upcoming. It can also be involved during treatment to help take care of anything that comes up, any sort of musculoskeletal issue, to address any lymphedema that might be starting, anything that's going to impact someone's function and how they're getting around. After treatment, some patients might need some help rebuilding their endurance. They might have some cancer-related fatigue that we can also address with different modalities and some therapies. So the goal of rehab is just to help keep a patient as functional as we can while they're undergoing their cancer journey.
Thank you. And you mentioned some patients needing a little help before breast cancer treatment. But can you talk a little bit about prehab and what patients might benefit most from prehab?
Yes, so prehab can be very beneficial for a lot of patients. Anyone who might be ready to undergo treatment who's a little bit deconditioned or who's having some trouble with mobility could be a good candidate for prehab, because we really want to optimize the patient's function, because some of these treatments can kind of take it out of patients a little bit. So we want to make sure that they are just as good as they can be going into it. The prehab program, we have a home exercise program that we can teach people in office if they're able to be a little bit more independent and might not need supervision while exercising, which a lot of patients like because they can do it on their own time at home. We also have the START program through Mary Washington, which is a cancer rehabilitation program, and there's a big focus on prehab, so patients can get skilled therapies with a physical therapist to really work on building endurance and safety with mobilization prior to undergoing treatment.
Great. Thanks, Dr. Coggins. So Jin, I'd like to spend a little time chatting with you. When I introduced you earlier, your title is Integrative Medicine Coordinator for the Regional Cancer Center. So can you talk to us a little bit about integrative medicine and what it is?
Sure. Good evening, everybody. So integrative medicine is an intentional use of therapies that you think of in massage and yoga and things like that that are purposely used to enhance the treatment plan for a patient. So when you talk to the oncologist and specialist and hear what's going on with the patient, for their symptom management, you want to incorporate those therapies at a time in which is going to enhance their overall wellness. So I am on my 7th year of cancer survivorship. Stage 2B, HER2 positive breast cancer was my diagnosis. And my family was transferred back here to the Fredericksburg area right when we found out about my diagnosis. So everything that you've heard up to this point is everything that I experienced. I had a whole team just kind of take me under their wing and get me situated. So when I kind of came to understand the development of the clinical and support services of the team, integrative medicine was one of those, and I built my understanding of it, and now I coordinate.
And so as a patient, did you take advantage of those integrative medicine programs, and how did you benefit from it if you did?
Yeah, it was, for me, it was a little bit more of yoga and massage, but I don't think I realized, right? It was understanding that those therapies were really beneficial, in particular to me, nausea, fatigue, some of those things. I had surgery, chemotherapy, and radiation. So I think it was when I started to talk to these specialists that were so, fortunate to work with, the therapist, in helping me understand that. Then I started to explore it that much more, to use it and continue to use these things in my survivorship.
Thank you so much, Jen, for sharing your story with us.
Sure.
Finally, Ashley, you've been with us for a couple of these Ask the Expert events, and we love hearing from you about all of the great things that you do at the Regional Cancer Center. Can you share with our viewers a little bit about your role at the Regional Cancer Center?
Sure. So, first of all, some people may never have heard the term navigator. So, just to kind of give you a definition of what we do, we guide patients through the healthcare system and help them overcome barriers to care. So practically, what does that mean? We are a resource and advocate for patients and their loved ones. We address questions, concerns, work through complications, and just offer general guidance on next steps from diagnosis to survivorship. We do patient education, coordination of care. You've got a lot of doctors. So for a breast cancer, you may have your primary or OBGYN, your radiologist, a breast surgeon, a medical oncologist, a radiation oncologist. So it's a lot. So we kind of help people work through that. We are a liaison between Mary Washington and community physicians. We keep the lines of communication open. And then we help you access the free resources through the Cancer Center and in the community as well. So that's kind of a segue to tell you about the free resources that we have through the Cancer Center. We have currently three cancer navigators. We're all registered nurses. We each have a specialty, and my focus is breast and GYN. We also have a licensed therapist, and she is available for one-on-one counseling via phone or in person. We have support groups that are virtual right now. We have site-specific groups, so we do have a breast group, a head and neck, and a prostate. And then we have a coping together, which is for everybody. And then, of course, we have integrative medicine, like Jen talked about, a nutrition counseling from a registered dietitian, genetic counseling, financial counseling, can help you tap into Medicaid or charity through the hospital or medical imaging, transportation assistance. wig resources, and also a certified mastectomy bra fitter. So we've got a lot of stuff to offer.
Thank you, Ashley.
You're welcome.
I do know that the Mary Washington Healthcare Regional Cancer Center is accredited by the Commission on Cancer and the National Accreditation Program for Breast Centers. So can you tell us a little bit about these accreditations and why they're important for our patients?
Yes. So as Emily said, our program is accredited through the Commission on Cancer and the National Accreditation Program for Breast Centers, which is NAPBC for short, which is a special designation for breast programs. Both are voluntary accreditations through the American College of Surgeons. And that's important for you to know because there are high standards we have to meet to become accredited. So we do this through quality measures, improvement projects and goals. One project that I've been involved with this year is called a Barrier to Care project. So the goal is to help our financially challenged patients have access to free or low-cost dental care. Sometimes dental work can be a barrier to starting or continuing treatment. So that's just one example. And then community outreach like this event. And as Emily said, we've also done town halls earlier in the year on testicular cancer and colon cancer. So you could check those out too. And we do all of this for the benefit of outstanding patient care. We also have all board certified cancer specialists. And as Dr. Mehta mentioned, we have tumor board meetings. So these are weekly meetings to review and discuss patients with a diagnosis of cancer. We do have a breast-specific tumor board and clinical team, and these tumor boards consist of the entire clinical care team from physicians to nurses and support services. Plus, Mary Washington Hospital is a magnet hospital for nursing excellence. So basically, you know Mary Washington is very committed to your cancer care.
Awesome. Thank you so much, Ashley, for
welcome.
telling our viewers a little bit about the accreditation and what it means for their care. We do have some questions coming in from folks in our community. They've been taking in a lot of the great information that our panel has shared, and so they want to get more, which is great. That's why we're here. So one of the questions coming in from the community is about screening. So Dr. Talukdar, somebody is wondering if they can get screened earlier than age 40, even if they don't have a family history. Could you speak a little bit to that?
Yeah, I think screening is a individual kind of decision, the decision that's also made in conjunction with your primary care. There are patients that sometimes will get a baseline mammogram at age 35 and then wait till 40 to start. There are other people, who have concerns, or a lot of times it's, you hear a close family member or friend that gotten breast cancer and you want to just kind of make sure. So I think have that conversation with your primary doctor, whether it be your primary care doc or your OBGYN, but, certainly you can have it, earlier than 40 if you.
Thank you. And Ashley, we have a question coming in for you. One of our viewers is wondering if there's a program to help people in our community who don't have insurance and need to have those screening costs covered. Are there any resources available through the Cancer Center?
Yeah, so if a patient came to us with that issue, we do have our financial counselor who helps us with things like that. Number one would be applying for charity through the hospital and possibly applying for Medicaid. We do work closely with the MOS-free clinic, getting patients in who are without a primary care doctor, who are uninsured. So we definitely have resources in the community for that.
Thank you, Ashley. Another question that we have coming in for you, Dr. Mehta. Some patients or members of our community are curious what common side effects patients might experience from chemotherapy and radiation.
So I'll touch base on the chemotherapy side effects, and in general, we'll touch base on the radiation also. So I've been doing this for the last 15 years, and every time I have to discuss chemotherapy, the first question I get is, am I going to lose my hair? That's a very important question because it not only changes the physical appearance completely, but also has huge psychological effects. So hair loss traditionally has been the biggest concern for patients that have to undergo chemotherapy. What are the things that we could do about it? I'll go over it later on after I go through all the side effects that are common. Another one is fatigue. Whether someone undergoes chemotherapy or radiation therapy, fatigue is very common. And as Jen had mentioned earlier, the integrative medicine helps a lot in dealing with that issue. Nausea, vomiting, lowering of blood counts, suppression of immune system, increased risk of infection. Those are some of the common side effects of chemotherapy. When I started practicing oncology, those days, people just had to deal with it and get through this in one way or the other, but that doesn't hold true anymore. Now, I think the science has advanced enough. We have enough resources and tools where we can prevent hair loss to the larger extent. There are devices like cold caps or scalp cooling devices that women use while undergoing chemotherapy, which will prevent about 70–80% of hair loss. Yes, there will be a lot of shedding, but only you would know that there is more hair loss. The outside world would not notice. So if you were to go to Walmart and you're shopping, no one's going to look at you with those looks and eyes because no one's going to even know about it. Nausea, vomiting, we give very strong medications to prevent one from having nausea, vomiting. So that side effect is largely controlled that way. Immune system dysfunction, we have tools at our disposal where we can give growth factors and injections to boost up the immune system and prevent those infections that possibly could happen. So we handle those chemotherapy side effects in a way where you're able to live life and you don't have to live cancer. And that's very important because this is the disease that you want to put behind and move on with your life. Now, chemotherapy is only one of the aspects of treatment. Another one is the hormonal therapy, which has sort of long-term consequences because you have to take the pill almost every day, sometimes for 5 years, sometimes for 10 years, sometimes lifelong. And those pills work by decreasing the level of estrogen in the body, which means you have muscle ache. Sometimes you feel like menopause-like symptoms and going through menopause all over again. It can increase the risk of blood clots. Sometimes it can weaken the bones. So we would monitor those effects, mitigate it, use multidisciplinary approaches, including integrative medicine, to handle all of those effects and side effects. And this entire journey, your oncologist would be your best friend and your guide because it's going to be a long-term relationship lasting 5 years, 10 years, 15 years.
Thank you, Dr. Mehta. We have another question coming in from a member of our community. Ashley, I think you might be the best one to answer this. If for a patient who's coming to us with breast cancer, they're wondering if Mary Washington Healthcare can take care of all of their clinical needs.
Yes, we are full service. So from imaging to breast surgery, and then we don't have medical oncologist on staff here, but we do partner with some of the area groups. So Dr. Mehta is one, and then we have radiation oncology. And then of course we have all the support services that I mentioned here at the Cancer Center here at 1300 Hospital Drive.
Thank you, Ashley.
Mm-hmm.
Jen, we have a question coming in that I think you can answer as a breast cancer survivor. So we have a person wondering what we would recommend after treatment has ended, even years down the road. Just mentioning some of the physical and mental toll that the diagnosis can take, and especially a fear of recurrence. This is coming from a 15-year survivor who's worried about everything. So what advice do you have for a fellow survivor?
Well, first I would say I would love to see them at our integrative medicine program because we have all of those programs, because that's exactly what I'm doing, because it addresses physical, spiritual, mental health. I think the other thing too is the best thing I've ever done for myself is to make sure I keep every annual appointment. And I mean, you know, primary care, oncology care. You know, some of the people that are on this panel have given me some of the best pep talks of my life and keeping me understanding both the clinical side of my cancer and understanding why we're doing what we're doing, and then all those things. So keeping up with visiting the professionals that can remind you kind of you're doing great and keep at it, and then asking for help in the support mechanisms, whether they're in the community. Some people seek it through church or other organizations, but this is exactly why we created the integrative medicine program about 5.5, 6 years ago. Come see me.
Thanks, Jen. Ashley, we have another question for you coming in. What would someone need to do in order to be tested for the BRCA gene? Can you talk a little bit about how our genetic counseling program works?
Sure. So that is a service that we have here. So the actual consult is a free service, and it's done virtually. So we have a partnership with VCU genetic counselors, and we can just get a referral from your physician, although it's not necessary, and it's easy to schedule that. Basically, just call your navigator, and we will help you get that set up.
Thank you, Ashley.
Mhm.
Dr. Coggins, earlier, you and Dr. Blanchard both mentioned lymphedema. Can you talk to us a little bit more about what lymphedema is and how you work with patients?
Absolutely. So lymphedema happens whenever part of the lymphatic system, meaning our lymph nodes, get somehow damaged, and so some of the lymphatic fluid that circulates throughout our bodies can't drain and circulate well. After breast cancer, this typically happens in the arm or in the chest wall. There's many risk factors for it. Not everyone gets lymphedema who undergoes surgery or radiation, but it can happen. So that's why we like to talk about it early so that patients know what to look for and know how to prevent it. Lymphedema, frequently patients will come in and tell me their arm feels heavy or tight. And that's the first sign. You don't usually see swelling at that point, which is great. We want to treat it before you see any swelling. And so to treat it, we frequently send people to a specialized therapy called lymphedema therapy. These are certified either occupational or physical therapists who have been trained in lymphedema management. And they do something called complete decongestive therapy, which is basically saying they're going to drain that lymphatic fluid that's stuck in your arm. They're going to help drain it through those lymph nodes that are left working well. We help to keep the swelling down by using compressive garments. So it's just an elastic sleeve that patients wear to help keep that swelling down. Prevention wise, the big thing people can do is just try to keep that arm kind of safe, making sure that their skin integrity is maintained. I tell patients to garden and they're at risk for lymphedema in their arm, wear gloves, wear a long sleeve so they don't have to worry about getting scratched or something like that by a thorn that could trigger lymphedema starting. Not everyone who is at risk for it will get it. So we just like to counsel people early on what to look for. So if they do develop lymphedema, we can get the team involved to get it treated so it doesn't progress to obvious swelling that people get more concerned about.
Thank you, Dr. Coggins. We are coming up at the top of our time for this evening, but we do have just enough time for a couple more questions. Dr. Talukdar, some of our viewers out there, may be hesitant about scheduling a mammo. They maybe are feeling trepidatious about the actual procedure or what they might find out from it. So if someone at home is on the fence or hasn't made that call yet, what do you want to tell them? What should they know? And also, do they need a referral to get a mammogram?
So you don't need a referral. You can come in. You can actually dial. It's a pretty easy number, 741 X-ray. So really easy to remember. Just dial it and we'll get you in. I think it is scary. It's the fear of the unknown. It's the fear of what might happen. It's the fear of pain from a mammogram. Mammograms are not the most comfortable procedure. but they save lives. I would say come in with somebody else. Sometimes that helps. Come in with a loved one, come in with somebody else that needs their mammogram, take them with you. Prior to COVID, we used to have manicure mammo events, and those were great because they were a little bit more fun. We'll hopefully get back to that soon. But, at the end of the day, mammograms save lives, but we can't save your life. We can't detect that very, very small cancer if you don't come in. You ultimately are the one that really kind of takes charge of your health. And getting your mammogram yearly is one of the best things you can do to make sure that you have a long and productive and happy life. So please come in.
Thank you, Dr. Talukdar. And finally, Dr. Blanchard, closing thoughts from you. What advice do you have for patients, who are coming into your office with a recent breast cancer diagnosis? What would you want those patients to know?
That's a really good question. And honestly, our Navigator program has been instrumental in putting the patient grounded and giving them starting information. So they come in with all kinds of questions. And what I like to do for patients who come in is to kind of go over the groundwork, go over everything. I show them their images. I show them the pathology. I don't want them to Google a whole lot. If they're going to Google anything, national accredited boards, organizations, NCI, NCCN, things like that, not, hear from what other people tell you. So come with an open mind, essentially, whenever you have a new diagnosis. Yes, get the information, but don't come in and say, well, my friend and my friend's sister or my friend's, mother went through this. That's not you. Every cancer is different. Every person is different. And I don't like to treat a patient as a cancer. I treat the patient. You have to take in the characteristics of the tumor, the underlying patient characteristics. To me, that's the most important thing. One of the most important things too for me is education, is to let them know that this is something that they can beat, and I like to prepare groundwork for them. And again, I think the Navigator program is essential. And I also want to point out that it might seem like we have a fragmented system. We have all these specialists, all these things available, but it is a very cohesive group. I know we had mentioned the tumor board once before, and it's a combination of all of us specialists getting together. And again, we don't treat the cancer, we treat the patient. And not everybody is treated. In fact, nobody should be treated exactly the same. So this is individual. And I like the patient to be empowered and to be a very important part of their own decision on what they want to do.
Thank you, Dr. Blanchard. And actually, one last question that just came in. Can men get breast cancer?
Oh, absolutely. The men have about 1% incidence of breast cancer that women do. And that's mostly because men have 1% of the breast tissue that women do. A lot of times it can be genetic. If there's the BRCA mutation, that can increase a man's susceptibility to having breast cancer. But in all honesty, I've treated a lot of men who are not positive for the BRCA mutation. And they pretty much present the same way. They have a lump. I've had nipple discharge. I've had men who have had, skin changes to their nipples or lumps under their armpit that they come in for that. Sometimes they're a little bit later to present because they don't think they can get breast cancer. I've also had a number of men coming in, their wives have actually pointed it out to them. Hey, you have a lump and you're not supposed to have it. So yes, men can get it. The overall survival is essentially the same stage for stage as our women. But again, a lot of times they catch it a little bit later.
Thank you, Dr. Blanchard. That's very interesting information to share with our community. Well, we are at the top of our time this evening, and I do want to thank our panelists tonight for sharing your time and expertise with our community. And of course, I want to thank you, our viewers, for tuning in to Ask the Experts. If you have questions about breast cancer or want to learn more about our services, we invite you to visit our website for additional resources. You can find us online at cancer.mwhc.com. And be sure to watch the Mary Washington Healthcare Facebook page and other social media channels to stay informed of the latest health and wellness information for our community. Again, many thanks for joining us this evening. Please stay safe and healthy and have a great night.